I'm very glad and honored to give my talk today on artificial intelligence in the field of medicine. I chose this topic today because I believe it's a relatively hot area of research that's rapidly broadening its role in both clinic and research fields. So today I chose to go over very in general the basic principles of AI methodology and its current trends and future perspectives within our field of medicine. I'd like to start off with a brief introduction of who I am. I joined Dr. Chu as Dr. Chu introduced me last year in February, almost a year ago now, as a research scholar for my 1 year sabbatical. Sadly, my time is running out, and I'll be returning to Korea in about 2 weeks' time. So back home, I'm currently associate professor at Yonsei University. My practice is quite broad, including endo, oncology, and transplantation, because of our policy requiring each faculty to practice multiple specialties. Since graduating medical school at Yonsei, I've never had the chance to train or work outside so far. So leaving home and being here at UBC, observing excellent surgery, and seeing how much clinic is dedicated and well focused on basic and clinical research, also observing early adoption and abundance of infrastructure leading to early expertise in the field, and so on, are all priceless experiences that I'm really grateful for having here at UBC. A little bit about where I'm from. When someone asks me where I'm from and I tell them Korea, always the next question is North or South? Yes, we are always threatened by North Korean ICBMs, but this picture well represents how much South Koreans have become so insensible to these threats over the past 60 years. Actually, we have a nice and calm Oriental country with lots of places to stroll around. Also quite an early adapter to high tech, where we could easily find restaurants with robotic servers that we don't have to tip, and also very much a lot of great food. I recently noticed that Yonsei University is currently in global partnership with UBC for exchange students, and found that we also have many similarities in numbers too, although we're a bit lower in overall. We do both have ice hockey teams, and while you have 8 Nobel laureates, we have so far 0. Our college covers 4 hospitals within the metropolitan area of Seoul, sharing faculties and students. And residents are rotated every 2 months for training in each of these hospitals. Yes, we've done fairly well in overall during the past several years, with a recent big jump in medical school rankings. I'm one of 21 faculties in our Department of Urology, and here are some numbers representing our volume, just to give you an idea of where I'm from. So to head on to today's topic, I think the recent advancements in AI technology and its influence in all areas of industry, including healthcare, can now be compared to an inevitable tsunami. And I think it's certainly time to think about how to accept this change and how to come up with a decent way to apply this technology for improvements in patient care and also for ourselves too. A few years back, I thought it would be worth keeping up with this evolutionary trend shifting towards AI, and was lucky to receive some national funds as PI to perform a couple of projects. Although, of course, I'm a urologist and not an AI expert, my talk today will be based on my experience on what I've studied and observed while running these projects. As we all know, we are now living in the era of the 4th industrial revolution, featured by the fusion of AI, IoT, robotic technologies, etc., which converges physical, digital, and biological human innovations into a single platform. We're continuously facing an exponential increase in the number of AI-related startups, and these are only a list of some of them that are showing significant revenue. An easy way to forecast the future industry is to see where the money is going. And here we can see the market forecast trend showing an enormous transition toward AI-related hardware. Not only the money is heading towards investments in AI, but also research is being performed in all fields of medicine, with a huge increase in the number of publications associated with AI over the past several years. And along with these research and publications comes along AI-based healthcare devices, with now more than 350 FDA-approved products out in the market so far this year. So from these numbers, we should acknowledge that AI in medicine is no longer a future, but that it's already here and has become a reality. So in the earlier days of medical AI development, it's true that there have been hypes, fantasies, and also fears to AI application into practical medicine. Just only 5 years ago, some experts aggressively predicted that radiologists will be replaced by deep learning technologies. But now we know the answer to this, that this hasn't become true, that machines cannot yet completely replace humans, and that we doctors have our inherent roles in healthcare practice. So what were the evidences to such hypes and fantasies? And contrary to such expectations, what went wrong and what are the current limitations? Before we go on any further, I'd like to go over the basic principles or definitions of these terminologies. We've all been so much exposed to these terminologies through publications and the media. And at least for me, when I first started writing grant proposals on AI projects, I remember these were the first that I started searching out for. So are these terms basically the same concept with only different wordings, or are there any differences? Starting with AI, AI generally refers to a technique that enables a machine to mimic human behavior and can be categorized into artificial general and narrow intelligences. Artificial general intelligence refers to the technology of developing a machine that is capable of thinking and acting like a human in an autonomous behavior, as we usually see in science fiction movies. It's the AI of the future that hasn't yet become a reality. Artificial narrow intelligence, on the other hand, refers to an AI that can perform only a certain task that it's been trained for, such as face recognition cameras and self-driving vehicles. It's the present form of AI which already lies deep in our everyday lives. Then what's machine learning? Machine learning refers to the technology that's used to achieve AI, using algorithms trained with data. Machine learning is categorized into supervised and unsupervised learnings. In supervised learning, the machine is trained to learn the data based on labelings, or in other words, given answer sheets fed by humans. Say we want to develop an algorithm to identify an image of a hot dog. We'd have to train the machine with image features indicating which is a hot dog, why this puppy or this shoe is not a hot dog, and that a hot dog image should have a long brown sausage in between a bun. So through this training and learning process, the machine will predict the answer based on the probability of classification. But in unsupervised learning, humans don't need to label the data or tell the answers, but we only give the machine tons of hot dog images, and then the machine will train by themselves and interpret the images based on the patterns that they've autonomously learned. Now, the third terminology, deep learning, refers to the method that's used to achieve machine learning. The reason it's called deep learning is because it uses neural network algorithms, as you can see here, inspired from the axon and synaptic structures of the actual human brain. How these neuron connections work with each other to derive the answers or the output will be discussed later in my talk. So in summary of their relationship, to achieve AI, we need to use machine learning, which is its subset. And to achieve machine learning, we need to use deep learning methods. The current application of AI in medicine, I think, can be generally categorized into the following three types. First, complex medical data analysis to obtain unforeseen insight, which in this type of AI uses machine learning methods to reveal information which conventional or traditional statistics have limitations on, such as in genomic data analysis. Second, analysis and interpretation of imaging and pathological data, which is the most studied so far by researchers and current AI startups. And third, continuous data monitoring and pattern recognition for the prevention of early recognition of a certain disease. So to go further into detail of each one of these, an example of the first type of medical AI is an EMR-based platform developed by Google. This platform was trained using EMR data of UCSF and UCM to predict treatment outcomes such as the probabilities of in-hospital mortality, long-term hospital stay, and readmission. They not only used standardized data forms such as demographic and lab results, but also atypical form of data such as written progress notes. Back then, these Google's developments were considered quite a groundbreaker to AI research that Google engineers were the ones to give the keynote speech at the 2018 AACR. Another example is IBM's Watson, which is the most well-known and which gained attention when it first appeared in Jeopardy in 2011 and beat former human champions by far. With this event showcasing the power of AI, IBM went on and targeted for cancer predictions, specifically lung cancer to start with. The idea here was to use Watson's computational strength in rapidly ingesting thousands of research papers, guidelines, results from clinical trials, and actual patient cases from NSKCC to develop a decision support system. This system would assist in making better treatment decisions, provide assurance, and screen for potential malpractice decisions made by humans. So this is a glimpse of how Watson for Oncology worked. On the first input page, patient demographics and tumor information are entered that are potentially associated with treatment outcomes. And then when you press Ask Watson here, potential treatment options are given according to the levels of recommendation. And when you click on these blue tabs here, they give you supporting evidence on why the specific recommendation was given. So after the launch of Watson Oncology in 2015, many worldwide institutions, regardless of their volume, adopted this platform, especially many in the US. I also remember 2 hospitals in Korea. I also remember a survey back then done on patients, which asked whose treatment recommendation they prefer to follow. And surprisingly, more than half of the patients chose Watson's recommendations rather than their physicians. The early experience and clinical feasibility of Watson for Oncology was presented at the ASCO 2017. In this study, concordance rates for treatment decisions between Watson and human experts showed generally high concordance rates for all the 3 types of cancer studied, and also according to their stages. So Watson, back at this time, seemed quite promising, but since then, I've never heard much about Watson from any publications or the media. So I searched for its latest news on what's going on and found that since its launch, it's become nowhere close to broader distribution or success, but that its parts have been sold off. Many explanations have been given for Watson Oncology's failure, such as the lack of evidence on generalizability, because the platform was developed based on US-based treatment guidelines, and specifically NSKCC data. So they failed to give options that aren't available in different parts of the world. Also, utility issues. Since each country or institution has different healthcare infrastructure and reimbursement systems, the actual utility of this platform on clinical practice was considered questionable. So this all adds up to the most important reason for its failure, that Watson overlooked the directionality of AI in healthcare. A good answer is always preceded by a good question. So rather than asking who or which does it better, or whether machines can replace doctors, we should rather be asking, by using AI, how can we better achieve the goals in medicine, since this is a solid goal that's unchanged? And how can we improve clinical practice by using AI in the correct direction? And we also need to acknowledge what the machine is good at compared to us to find a spot where the machine can fit in to augment our capabilities in achieving these medical goals. The next type of AI in medicine is imaging and pathological data analysis and interpretation, which is the most studied and developed so far. As previously shown, this type of AI is the most studied and developed by researchers and the industry, mostly in the field of radiology, and not much so far in urology. This diagram of the artificial neural network that I've shown earlier depicts the basic concept of deep learning, which is the most widely used for this second type of medical AI. Neurons, represented in green dots, are the core identities of the neural network where the whole information processing takes place. Human-fed data is entered as neurons in the first layer of the neural network, and this is referred to as the input layer. On the right end is the output layer with hidden layers in between. While the information is transferred from one hidden layer to the next, the neurons with correct answers, represented in red dots, for example, gets activated and sends on the information to the following layer until the very last. This is called the training process, which is continuously repeated and adjusted to produce a well-trained network. The more hidden layers there are, the more training and learning gets performed, resulting in more accurate predictions. And this is why the recent advancements in computational power has led to a boom in recent AI techniques, because adding just one more hidden layer to this neural network requires decades of huge improvement in CPU or GPU power. This is why, although the concept of neural networks in research dates back to the 1990s, it wasn't until the 2000s that AI started to gain attention in research, along with significant advancements in computational power. This shows an example of how the advancements in computational power has transformed deep learning technology to another level. Say we'd like to develop an AI model for identifying long nodules from plain X-ray films. The past models on the top A, with less computational power, were trained based on predefined features such as texture, shape, and histogram patterns of the nodule, labeled and fed by humans. Then based on these annotated features, the machine would draw a conclusion based on the probability of classification. But nowadays, as we see in the bottom B, high-powered CPU or GPUs allow the machine to perform convolutional neural network algorithms, which learn the data in a more autonomous way, sometimes even without the need of any human-fed labeling, and also with more features and layers, resulting in higher predictive performance. So through such advancements, distinguishing between these puppies and chocolate chip muffins, which used to be performed inaccurately before this advancement, has now become easily doable. To go over some examples of this second type of medical AI, this platform developed by Vino calculates bone age from plain X-ray films. The clinical utility of this platform was studied, and as you can see from the bottom left, the platform's accuracy was higher than the fellows and residents. And notably, the combination of AI assistance with the skills of the fellows and residents resulted in a synergistic effect in accuracy improvement. And also on the right, they saw that AI assistance was able to reduce the total time needed for the readings. Studies have also been performed in our field of urology. Here, whole man prostatectomy specimens were matched with preoperative MK-MRI for AI detection of cancer lesions, which showed excellent performance. I think such image reading technologies could be especially be useful in clinical scenarios in which subjective or debatable decisions are needed to be made, such as for PIRADS readings. We saw from the precision trial that the distribution of PIRADS-3s, which is an I don't know zone, can be extremely variable depending on the radiologist or the clinical infrastructure. As we can see here, total red in blue and central red in red. And what we saw was that there's a major difference in the distribution of PIRA-3 readings. I think this is a good example of where AI can fit in and improve clinical practice to another level. Also for bladder cancer, AI was trained to identify tumors from cystoscopic images, and I think this platform could especially be useful for identifying small tumors or flat lesions such as CIS, of course, if it can be done in cystoscopic real time. But there's always a but. Dr. Bouchner, past editor of JAMA, mentioned at the Stanford Medicine Grand Rounds that they won't be any longer accepting papers looking at medical images, only showing that machines are as good as humans, that this is already so well known, and that future studies of AI should address the clinical impact or the synergistic role of AI on clinical practice. So in which direction, remember we talked about directionality, should future AI research focus on? The ground opinion is that future AI should no longer address issues on just better accuracy compared to conventional statistics, but will need to show that the application of AI can actually translate into better treatment outcomes and better synergistic effect with us humans in terms of efficiency and cost. And also not just focus on a single disease, but should expand to a wider disease spectrum. Also validate its feasibility in actual practice through prospective RCTs or external validation, and also focus on studies beyond what's been possible by human perception or cognition. So I think these are the key points that we should look out for to get our work published in a good journal, get the algorithm translated into actual clinical practice, and to obtain reimbursement from national healthcare systems. So in light of these key points, our team recently aimed to develop a model to distinguish uric acid from non-uric acid stones with external validation and with a clinical implication that with correct prediction of the uric acid component, patients with high-risk morbidities could be spared with surgical intervention and rather be offered a more conservative alkalization therapy. So with UVC data, we trained DICOM CT images using a convolutional neural network algorithm called ResNet-18, and then converged demographic and clinical data as a fully connected layer for the final classification of the stone. So this was a supervised type of machine learning, as we've discussed before, in which each of the kidney and stone contours and component information were human labeled and fed into the neural network. So after the development of the model, we finally used an external cohort from Yonsei data, since of course, external validation is important in developmental AI studies and always essential to get into a high impact journal. So our model was able to achieve 100% sensitivity in detecting kidney stones in each patient. And as you can see from the image, the machine was able to accurately delineate the kidney and stone contours, just as we annotated them for the input data. The prediction accuracies were analyzed according to binary and multi-class classifications of the stone. For the binary classification, a model was trained to stratify stones according to uric acid versus all other non-uric acid stones as a whole. In this model, compared to the conventional logistic analyses, machine learning was able to achieve close to 100% accuracy in distinguishing uric acid stones. The accuracy in the external validation model was also high at 97.1%. For the multi-class classification, the model was trained to stratify stones according to uric acid versus specifically calcium oxalate, struvite, and cystine stones. In this multi-class model, predictive performances were relatively lower compared to the binary model, presumably because of the lower numbers of subjects used for training in each group. Still, all values were relatively within clinically acceptable ranges, although the performance on external validation for calcium stones weren't as high as we expected. So based on our results, we came to the conclusion and were able to give the message that this AI model can be reliably used to select candidates for embolization therapy in patients who we want to be spared with surgical intervention. The third and last type of medical AI is data monitoring and disease prevention, which can be compared to cars with tire pressure sensors, which continuously monitor tire pressures and alarms you before you actually get into trouble. Examples of this type of AI in healthcare can be wearable devices that monitors your physical or vital signs and warns you when there are significant changes or threats. This study is also an example performed by our infection department colleagues at Yonsei. And here they developed an AI model to early identify sepsis in ICU patients using multiple clinical parameters. The aim of this model was to predict septic risk to provide chances for preemptive measures before the patients gets actually into trouble. This study being based on a research MOU agreement back in 2016 between Yonsei and Severance AI, which is a Korean AI industry. This MOU back then was to encourage AI research for Yonsei faculty by waiving fees for consultation and analysis, since we doctors aren't familiar with analytics, while the industry always needs clinical data for development and testing. So I think this was a win-win strategy for both parties, which also served a good chance for me to start on AI research. So back then I started off with a rather simple study design to predict survival outcomes of biopsy-proven prostate cancer patients according to the initial type of treatment. We used patients from our institutional database and aimed to use a multi-layer perceptron long short-term memory artificial neural network model, which is a supervised type of machine learning known to be most suitable for time-dependent survival analysis. Clinical pathological data at the time of prostate biopsy were retrospectively reviewed, as well as survival outcomes, including progression to CRPC, cancer-specific, and overall mortalities. Since the quality and quantity of the input data with minimal missing values are most important for high-quality training and output results, it took us almost 2 years to complete and clean the database, despite having a backbone data to start off with. And I remember this was the most toughest phase of the project because we had to spend so much time, personnel, and money, not knowing whether there will be any meaningful results. But luckily, results were relatively satisfying within clinically acceptable ranges. And although not shown here, all accuracies were significantly higher than the conventional Cox regression. We also performed external validation using outside data, and it's a bit hard to read the numbers here in the table, but performances were generally even higher than those that we got from the development model, and also calibration plots were good. So based on our developed model, we posted an open access website and an app for clinical use, and it's currently embedded into our EMR system and being used by my colleagues and I in the clinic as a patient-specific visual tool during patient consultation. So here we not only found that the machine can do better than conventional statistics in terms of patient-specific survival estimates, but also that AI can actually synergistically help us to make a better shared decision-making process. So finding such tool being clinically useful, our team went on and aimed to develop another patient-specific AI model. This time, that gives us an optimal sequencing strategy of systemic CRPC agents. We used multiple clinical pathological variables of CRPC patients from our site to develop prediction models using extreme gradient boosting and random survival forest machine learning methods, which were all human data-feeded supervised learning methods. Survival endpoints were cancer-specific and overall mortalities according to the uses of abiraterone, enzalutamide, docetaxel, and cabazitaxel. The final model was stratified according to first, second, and third line models to separately reflect the changes during the previous lines of therapy. As a result, the XGBoost model showed the best performance among all machine learning methods, with significantly better performance compared to the conventional Cox models. Again, we developed and posted an online website with open access, which provided not only the best sequencing options in terms of mortality risk scores, but also showed SHAP values, which were the rate of contributing factors on each survival outcome, which gives us a chance for early identification of risk factors and early intervention for maximal survival outcomes. So from these studies, I think the role of machine learning in urology or in the field of medicine in overall would be most applicable for clinical questions that don't have a standardized guideline or those that have a weak level of recommendation, so that it could help treatment decisions that are prone to physicians' subjective preferences. Also, for topics that need analyses that conventional methods have limitations on, I guess we've all had faced the limitations of conventional statistics, especially for survival analyses in which the nonlinear and multidimensional features aren't fully accounted for. Also, the limitations of current guidelines is that they're constructed based on clinical trials and nomograms, mostly based on Kaplan-Meier and Cox regression. And the limitation to this is that the given recommendations are based on the grouping of patients according to the average risk of the disease and are not patient-specific. So to overcome these limitations and to provide a better patient-specific recommendation in real life, I believe machine learning has the potential to provide more clinically useful tactics compared to conventional statistics. Lastly, I'd like to share another nationally funded project that I thought worth doing in the current era of COVID as another example of medical AI used for disease prediction. As we all know, the pandemic has posed a huge burden on healthcare resources worldwide. However, current COVID guidelines doesn't provide an optimal triage protocol according to the relative ratio between new patient influx and available medical resources. So we aim to develop a prediction model with COVID disease severity as the endpoint, and based on this model, to develop an adaptive triage model for optimal resource allocation under limited healthcare resources, specifically ICU capacity. So the basic concept here was to first use a machine learning algorithm to triage patients who really needs ICU care from those who can just be isolated and observed at home. Then second, this information will be sent over to the main national server, which will send a mobile clinic with pressurized air chambers to minimize the spread of the disease during patient transfers. The communications within the system in overall was agreed to be handled by Kakao Mobility, which is currently basically the Uber of Korea. So using the open national data set of COVID patients, we developed 4 models according to the extent of input variables so that restricted models, such as models 3 and 4, can be used in healthcare settings with limited resources. For instance, here in model 4, we eliminated all input variables that are needed to be collected from healthcare facilities, such as lab results, so that patients can estimate the risk of progression to severe disease and the risk of actually getting hospitalized with just a few clicks at home. So as a result, according to the disease severity endpoints, the XGBoost model provided the highest prediction power compared to other methods. So we used this unspecific model to create a threshold optimized algorithm that accounts for the volume of patient influx relative to the daily ICU capacity so that the overall mortality outcomes can be minimized within that society. So after publishing our study early last year, we posted our model to an open access website for worldwide use. And since COVID was such a big issue back then, we did gain some attention from the news media. We are now continuing discussions with the Korean Ministry of Health for allowances for actual clinical use. But since the gravity of interest in COVID isn't as high as before, progress is rather slow right now. So we've now seen 3 types of AI applications in healthcare, reviewed the concepts of AI, machine learning, deep learning, examples of 3 types of medical AI, and also how the advancements in computational power is boosting the level of AI technology to another level. However, there are a lot of remaining issues to be solved. Machine learning needs to be trained with a huge amount of data. The more data you train them with, they'll give you more accurate results. But how much data should be considered sufficient, and from where and how to efficiently collect this large amount of data is still unanswered. Also, who owns the patient data, patients themselves, or the facility that collected the data, and to which extent this data should be open and shared, are also remaining issues. Also, we know that in medicine, there are many questions in which there is no one answer to. How to set reference standards and how to define normal values, and also technically overfitting issues will also be needed to be addressed in the future. Also, how to validate the results given by the machine, how high we should set the level of standards to be applied to clinical practice, and also all sorts of restrictions and regulations. How to obtain healthcare insurance, cost analysis, and how to evaluate safety measures, and in case of malpractice, who's to blame and how much to blame. All these are unsolved issues that need to be addressed for AI to be successfully blended into real-life healthcare. Physician burnout is currently a big issue that's unaccounted for in many modern healthcare settings, which can lead to lower individual performance and lower quality of patient care. There was also a recent tweet of a survey result from the Occupational Information Network that we have the #1 most stressful job among 873 jobs that were surveyed. So by using AI and through further advancements in its techniques, we hope to improve accuracy and cut time in diagnostics, improve the efficiencies of practice and patient care, improve prevention and prediction of disease, and by successfully achieving these through AI, we'll maybe to use AI as a breakthrough to reduce physician burnout and ultimately better patient care. Thank you for listening, and special thanks to our team and Dr. Chul for his supervision and for arranging my stay here at UBC. Thank you, and I'm open for questions or comments.